If you're a part of the roughly 85% of the population that struggled with back pain at some point in your life, well then the thought may have crossed your mind as to whether or not you could get some relief by dangling yourself upside down from your ankles. You see, inversion therapy and spinal traction are two topics that I receive questions about all the time. And so in this video, I'm going to talk about the strengths and the weaknesses of this therapeutic intervention, who this type of therapy is for and who it's absolutely not for, and the best way to use it. First, let's define the term so that everybody's on the same page. With inversion therapy, a person is suspended upside down, usually hanging from their feet or ankles, and the traction or stretch on the spine comes from the weight of the body being pulled downward by gravity away from the anchor point. The most common example of this is an inversion table. Now with spinal traction, the setup is usually a little bit different. A person is usually lying flat on their back, their upper body is secured in place with some sort of strap or harness, and then a mechanical force is transmitted longitudinally through the body. A typical setup usually looks something like this. But the goal with both of these treatments is the same, and that is to apply a gentle stretch to the paraspinal musculature, to create some separation between the vertebrae, to decompress the discs, and to reduce pressure on the spinal nerves. As far as the strengths and weaknesses of these two therapies go, there are plenty of both here to talk about. With regard to inversion therapy, its strengths lie primarily in the fact that it is a very low-tech treatment option. The therapy itself is incredibly straightforward. It also tends to be much less expensive on average than many of the bigger, more fancy mechanical traction devices. And finally, inversion absolutely has the ability to create significant distraction in the lumbar spine and a reduction in pressure in the spinal discs, and there's research to support that. And this pilot study that was published in the journal Disability and Rehabilitation is a great example. These researchers took a small group of people who had all been diagnosed with single-level lumbar disc protrusion causing nerve root impingement. In other words, they were having radiculopathy or sciatica-type problems that were due to a disc bulge or herniation at one level in their lower back. And because of the amount of pain and disability that they were experiencing, all of these folks had been scheduled for back surgery. The researchers took those people and they split them up into two smaller groups. Group number 1 received inversion therapy plus physiotherapy, and group 2 received physiotherapy only. Now, the physiotherapy here consisted of education and advice about the type of back problem that they were having and how to avoid or minimize symptoms. It also included specific exercises for movement control and reduction of mechanical dysfunction, as well as manual therapy techniques. In addition to that, the inversion group received 3 sessions of inversion therapy each week for 4 weeks. Each of those sessions consisted of as many as 6 2-minute-long inversions up to the tolerance of the person who was being inverted. So they would invert you for 2 minutes at a time and then repeat basically as many times as the person could stand it. What they found after 6 weeks was that the group that was receiving inversion therapy, 77% of the people in that group were able to avoid having surgery, whereas the physiotherapy only group, only 22% of the people in that group avoided surgery. It's important to point out here that cancellation of the proposed operation was a clinical decision made by the patient's doctor, and it was based on the exact same criteria that was used to schedule the patient for surgery in the first place. So they had to show improvement in their pain and disability. One other thing that's important to point out here is that the researchers did before and after MRIs for all of the people in this study, and there were no significant differences between the two groups. In other words, the inversion therapy didn't lead to any physical or structural changes in the spine, but they were still massive reductions in the need for surgery in the group that was undergoing inversion therapy. In another study that was published in 2021 in the Journal of Physical Therapy Science, researchers took 102 people who had all been diagnosed with single-level lumbar disc protrusion, and they gave them a short introduction to inversion therapy consisting of 6 sessions in a clinical setting before sending them home with inversion tables so that they could continue the therapy on their own. At the end of 6 weeks, they brought these people back into the clinic for reassessment, and what they found was that 74% of the participants in this study had a reduction in their pain scores after 6 weeks. and 75% of them had a reduction in their disability scores. Really, really impressive. One other thing that was interesting about this study is that the researchers did a 1-year follow-up where, again, they brought these people back into the clinic, they questioned them about their back problems and how they'd progressed and how many of them had gone on to have surgery and how many of them were able to control their problems, minimize their symptoms, and avoid surgery. And what they found was that 21% of these people went on to have back surgery compared to 43% of people in the matched control group. So again, we see a 50% reduction in the need for surgery in the inversion therapy group. But I would point out that in this study, there are a couple of big red flags. First, there was a 22% drop-off in participation over the course of this study, which is pretty large. And the other major red flag is that this study was funded by Teeter Inversion Tables, who is one of the biggest producers of this type of equipment. So the results can be taken with a grain of salt, but still, when you match it up with the other study that I presented, there seems to be something here. And in fact, as a result of this type of research that shows success rates in avoiding surgery being so high, many surgical centers, both in the United States and around the world, now offer inversion therapy as a standard initial treatment for patients awaiting surgery for single-level lumbar disc problems. Unfortunately, inversion therapy also has some significant downsides, beginning with the fact that it requires a person to be inverted. And the thought of flipping yourself upside down is really unappealing and downright scary to some people. Also, getting into and out of that inverted position can be difficult for certain segments of the population, which adds to that fear factor. In addition to that, there are very real considerations about hanging yourself upside down from your feet for an extended period of time that relate to equilibrium, circulation, and blood pressure. And certainly that position is going to be problematic for some people. Finally, the application itself has certain challenges, namely that it's very difficult to regulate and know how much force you're putting through the spine, because ultimately it depends on the weight of a person's body and the angle that they're at in relation to gravity. But even then, you're sort of just guessing, and that doesn't inspire a lot of confidence. When it comes to spinal traction, the benefits begin with the fact that it's performed while lying on your back, which is a much more comfortable, user-friendly, and sustainable option than dangling upside down hanging from your feet. But spinal traction is also much more targeted than inversion therapy. With inversion therapy, the stretch is created by the weight of your body being pulled downward by gravity while your feet remain anchored in place. And that means that traction is being applied not only across your entire spine, but also through your pelvis, your hips, your knees, and your ankles. Whereas with spinal traction, many of the systems allow you to modify the vector of pull and/or the position of the lumbar spine so that you can direct that stretch exactly to the region of the spine where you need it and avoid putting it in areas where you don't need it. Also, with spinal traction, it's much easier to regulate and know exactly how much force you're putting into your lower back, which lends itself to both reproducibility and progression, and that inspires a lot of confidence. And finally, it has proven efficacy in the scientific literature. There have been at least 3 different systematic reviews published in the last few years alone on the subject of using mechanical traction for lumbar disc herniation and lumbar radiculopathy. And the conclusions from each of these 3 studies have been eerily similar. Here's the first one from a study that was published in 2022. Quote, mechanical traction can effectively relieve lumbar and leg pain and improve disability index scores in patients with lumbar disc herniation. But it has no significant effect on spinal motion. The therapeutic effect of mechanical traction was significantly better than that of conventional physical therapy. Here's another one that was published in 2021 in the journal Physical Therapy. Quote, the literature suggests that for pain and disability in lumbar radiculopathy, there is short-term effectiveness of supine mechanical traction when added to physical therapist intervention. And finally, a study published in 2020 stated that compared with sham treatment or no traction, lumbar traction exhibited significantly more pain reduction and functional improvements in the short term, but not in the long term. Unfortunately, spinal traction also has some significant downsides, and those center mainly around the fact that many mechanical traction devices are large, require complicated setup and assistance to use, so you can't do it on your own, and on top of that, many of these devices are extremely expensive. The other thing that has to be mentioned in any conversation about inversion therapy and lumbar spinal traction is that these two things are absolutely not a cure-all. They do not work equally well for all back problems. And that was evidenced by this study that was published in The Lancet back in 1995, where researchers took 151 people who had been diagnosed with non-specific lower back pain, which is far and away the most common diagnosis that back pain sufferers come away from their doctor with, and they split them up into two groups. Half of the people got mechanical traction 12 times over a 5-week period, and the other group got sham traction. And what these researchers found at the end of the 5 weeks was that there was no benefit whatsoever in terms of pain relief or improvement in disability from mechanical traction. And it's important to point out here that the efficacy and the impressive results that have been demonstrated in studies on these two techniques have centered mainly around a handful of really specific conditions. And those are lumbar disc bulges and herniations, especially single-level disc bulges and herniations, sciatica that's being caused by a lumbar disc problem, and lumbar radiculopathy, meaning low back or leg pain that's being caused by spinal nerve root compression. So with all that said, I want to show you the setup that I use in cases where lumbar spinal traction is likely to be beneficial. This is the Pentavac 2500, and it's made by a company called Posture Pump. And this little device has a bunch of features that I really like. First and foremost, it's a mechanical traction device that you use while lying flat on your back, so you don't have to go upside down. Second, it's very easy to adjust the device to the size and shape of your body. Third, you can fine-tune the treatment itself and direct the stretching forces into the region of the lumbar spine where you need it the most. So the Pentavac has two separate air bladders, one above and one below. Each is controlled by its own individual pump. So if your lumbar problem was more in that L2, L3, or L3, L4 region, what you would do is inflate the upper bladder to create more expansion and extension in the upper portion of your lumbar spine. If, however, your problems were down in the L4, L5, or L5, S1 region, you would inflate the lower bladder to create more expansion and extension in that region. Once you have the bladder set up to fit your back problem, you cinch up the waist belt and you engage the decompression pedal, which will lock the belt in place, scoop the sacrum underneath you, and create negative pressure inside of the discs themselves, which, when combined with extension, actually has the ability to draw disc material that's pushed backwards back into the center of the disc. And like you saw earlier from the conclusions of the 3 meta-analyses that I shared, when mechanical traction is used appropriately for conditions in which this type of therapy is indicated, it can make a big impact. If you're interested in finding out more about the Pentavac 2500 and this unique form of spinal traction, click the link in the upper right-hand corner of your screen now. I'll also put a link for it in the description down below this video. And if you want to know the specifics about how I use this type of mechanical traction in patients with lumbar disc problems and radiculopathy, leave me a comment down below. Once we get to 100 comments on this video, I'll create a follow-up where I outline my entire traction protocol for you guys. Beyond that, I just want to thank you so much for watching. Make sure to hit the like button and the subscribe button before you head out of here, and I'll see you next time.